Okay, here we're going to now talk about pain assessment and management in children. Objectives here are to discuss assessments of pain in pediatrics, appropriate assessments of pain in pediatrics, identify appropriate pain scales for patient age and development, identify different medications for pain relief, and discuss alternative methods of pain relief. So, when we're assessing our pain in our patients, we are going to assess, first of all, where is that pain? Developmentally appropriate assessments are either asking a younger child where they might feel the pain, having them point to the pain. As they get older, the adolescents can tell you exactly where that pain is and what it feels like, satisfaction with the treatment, how well what we did, our interventions worked. So if we gave them medication, we're going to assess them half hour later to see if those medications work. If we are using alternative treatments like ice or heat or distraction, we're also going to assess how those treatments are working for our patients. We have to ask about the symptoms. What are their symptoms? Is it aching? Is it burning? Did it come on suddenly? Is it chronic? Is it acute? And any other things that can make that pain happen. What are the factors that are related to that pain? And then we're going to talk about physical recovery. How are they recovering from that pain? How does the pain affect their physical recovery? If they're in a lot of pain, they're not going to be able to get up and walk. So if you have a patient with an appendectomy, you're going to make sure that you give them Tylenol or ibuprofen or whatever they have ordered about half hour before they actually get up and walk so that they are able to do those physical activities that we want them to do to be able to recover. And there also, pain has an emotional response. So pain can be tied to emotions. They can be tied to stress and anxiety. So we need to assess what their emotional response is to their pain and how to alleviate those symptoms as well. So when we're doing a behavioral pain assessment, we're going to look at different scales. And the ones that we're going to be concentrating on are really the FLAC scale, with facial expression, leg movement, activity, crying, consolability that we've already discussed during our skills lab. There's also a comfort scale that we generally don't use in the hospital. Children's infant post-operative pain scale, also not generally used in the hospital in our setting. And then there's a premature infant pain scale that you'd be using in a NICU setting. We've also talked about the Wong-Baker-Faces pain scale and the numerical pain scale for older children. So here's just a picture of your FLAC pain scale. It is a pain scale, and this is one you're going to be using most often, especially for the younger kids or kids that can't communicate, so nonverbal infants. They're sleeping, they're sedated, they can't tell you what their pain is. So we're going to look at different physical attributes and give them a scale from 0 to 2 and come up with a number between 0 and 10 and whether or not we need to intervene to help alleviate that pain or we do not. So first we look at their face. Are they grimacing? Are they constantly looking like they're in pain? They have a grimace on their face, especially for their infants. Their legs, are they moving their legs? How are they moving their legs? Are their legs pulled up into their body as a protective mechanism, especially for the infants? What kind of activity do they have? Are they comfortable? Are they constantly trying to change position to get into a comfortable position? Crying, are they consistently crying? Are they just intermittently crying? So we're looking at if they're just comfortable or not crying at all. And consolability, how consolable are they? Can we pick them up and help with their pain? Can we change their position and that will help with their pain? Give them a pacifier, help with their pain. So consolability, if nothing is helping with their pain, we're going to give them a 2 because we can't help alleviate their pain just through comfort measures alone. So we come up with a number between 0 and 10. Here's your Wong-Baker-Faces scale. This again is used for children 3 to 8 years old appropriately, that they can respond. You show them a picture, you ask them to point to that number that they are currently feeling. So look at their faces, and they can give you kind of an idea of where they're at in that pain scale. And again, this is a 0 to 10 pain scale, and you can put that in the chart and intervene based on what their pain scale is. Again, remember your patient and the age of that patient and the cognitive abilities and emotional abilities. So if they give you a pain scale, maybe they're pointing to the 8, kind of a grumpy face and happy face. And then we have to do a little bit more assessment there. Where does it hurt? Have them point to where it hurts. Can they describe how it hurts? Also understand that this in your assessments, is it really pain or is it something they don't just want to be here for? But we have to trust that if they show us that they're 8, 6 or 8, that they really are unhappy, and there's something that we need to do to help them feel better and comfort them. So then you have the 0 to 10 or the self-reporting pain scales. We talked about older than 4 years old. We can use simple and concrete words. Like I said, use age-appropriate terminology with your patients. We can use the Wong-Baker, the visual analog scale, or the numeric rating system. These are pain assessments that the children, they're self-reporting, so they're telling you what their pain is, and we're not having to guess by looking at them. So children with communicative and cognitive impairment, chronic illnesses, they're nonverbal, they may be autistic, or they may have a chronic illness and they're not able to actually communicate their pain or not communicate their pain well. So we make sure that we use the appropriate pain scale when we are assessing their pain. Also understand that there are some cultural differences in pain and how pain is expressed in different cultures. So you take into account what their culture is and what that culture may express their pain, and the children usually take their cues from their parents. So if it's a culture that is stoic and doesn't show a lot of pain, or if it's a culture that expresses their pain with crying or loud moans, we take that into account as well. And we have to understand the kids with chronic illnesses that experience a lot of pain, or they have complex pain based on trauma or burns. Their pain can be based on different complex medical treatments or complex medical diagnoses. Pain management. So when we talk about non-pharmacological pain management, this is when we try to help alleviate pain, not necessarily by giving the medication, but using strategies and different techniques to manage pain without using medication. So are they able to be distracted? Can we distract them with a toy or with a game or even with a tablet or TV? That can be helpful. Can we give them some relaxation techniques? Again, would be an age-appropriate intervention, where can we just have them sit quietly? We dim the lights. We make the room nice and calm, especially if they have aversion to lights, if they have a head injury or something that would be aggravated by lighting in the room. So do we close the curtains and turn off the lights and help them to relax? Positioning, again, would be a big one here too. Is there something we need to do in positioning? Are they uncomfortable in bed? If they look uncomfortable in bed, then we said, can we help you find a comfortable position? And we change their position, and that might help their pain as well. If they're old enough, you can try to use guided imagery, teach them about meditation, think about things that make them feel better. This is where the emotional response can come in, where if we can get them to a state of emotional, a better place, then they might have less pain. There are other things. Cutaneous stimulation has been used for infants. Again, containment and swallowing. If we swallow them up, will that help them feel comfort and take away some of their pain, their feelings of pain? Again, pacifiers, non-nutritive sucking can also help, and just kangaroo care for those infants, the neonatal infants, just being held by their parents, skin to skin, will that help with their pain? So again, this is very much depends on their cognitive and emotional and age of the patient, of what we can do for different distraction techniques. We're not necessarily going to try to get a 2-year-old to do guided imagery, that might not work for them. So make sure it's age-appropriate interventions. So complementary pain medicine. So if you want to use complements to the pain medicine that you're going to be giving them, some of these are biologically based, energy-based, mind-body techniques, alternative medical systems that you can look up and read in your textbooks. So a lot of what we're going to be doing in the hospital would be pharmacological management. So we talk about our non-opioids. What are non-opioids? Those would be our ibuprofen, our Tylenol, our Toradol, our ketorolac. So acetaminophen, ibuprofen, and ketorolac, those are non-opioid pain medicines. You have your acetaminophen, Tylenol, and these will be very effective if we can use them around the clock, especially for immediate postoperative, or if they have some kind of acute injury that we want to just kind of manage those pain. So opioids are another pain medicine that we use, and those will be your narcotics. Most likely you might give them a Norco or a Percocet, oral medications. Those medications are based on their pain levels, so we need to make sure that we give them the appropriate pain medication for their pain level. If they're reporting a pain of 3, we're not necessarily going to give them an opioid for that. We might give them a non-narcotic and use some of our other techniques in order to help with their pain. If they're reporting a pain of 7 out of 10 or 8 or 9 out of 10, yes, we are definitely going to help them relieve that pain with opioid analgesics. Co-analgesic drugs, so there are some drugs that are in combination with the opioids that we give that can potentiate those effects. So a lot of times you will see a Tylenol given with a narcotic. Those potentiate the effects. Ibuprofen with their narcotic. Those potentiate the effects, which means that what they do is they make those pain medications work better and last longer, so that we're giving less pain medication and give just what we need to give. Choosing the pain medication dosage, again, we make sure that we give the right medication for the right pain level. And in your orders, you will generally see a Tylenol given for a pain of 4 to 6, and then the opioid medication given for a pain of 7 to 10. So when we go and assess their pain, we need to make sure that we give them the right pain medication that fits that pain level that they are reporting. We talk about around the clock pain medication versus PRN medication. So around the clock medication, a lot of times physicians will write orders, or providers will write orders so that we can give them around the clock, so that we don't let them get their pain out of control. And this is usually used in acute, right after an injury, a surgery, a traumatic event, where we know that they will be experiencing pain for a period of time, and we won't want them to get their pain level too high. And then we can choose the PRN, which is as needed. So give them the pain medication as they need, as they're getting better, as they're healing. We can move to a PRN type of timing of our medications. Method of administration as well. So how are we going to give it? The methods of administration can be oral, it can be IV, it can be transdermal. They can have a fentanyl pain patch on or clonidine patch on. And also rectally, we can give infants, we can give rectal Tylenol. So we need to make sure that we're choosing the most appropriate method of administration. If they're NPO, we need to make sure that they have an order to take the medications while they're NPO. So make sure you look at their orders to see if they can get the medication. Are they able to take it by mouth, or do we need to choose another method of administration? PCAs, where they will have patient-controlled analgesics, so they will be set up with a pump, and they'll be given a button, and they'll be able to push that button whenever they're in pain. Now, the things that we have to assess is, are they cognitively and physically able to push that button when they are in pain? Can they follow directions? And whether or not this is the most appropriate pain control that we can give them. This is great when they have kind of a long-term acute pain. We're giving them medication around the clock, but also gives them a level of control of their pain too. So when you give them the control, it helps them feel better. A lot of times you can tell them, because there's a lockout on that PCA, we can tell them they can push the button whenever they're feeling in pain, and depending on the lockout and the timing of that pain medication, whether or not they'll be getting that dose, and that can help them feel a little bit better as well. When they feel in control of their pain, they're less likely to get stressed and anxious when they are in pain. So other pharmacological management, there are times we do epidural and analgesia. We won't be seeing that a lot, but that's when they have an epidural catheter and they are delivering epidural analgesics through that catheter in the epidural space. So it's usually they'll put a catheter in their spine, or in their back in the epidural space, and a anesthesiologist is the one that does that, and they manage it as well. So transmucosal would be your pain, something if you could put under the tongue to dissolve, or transdermal analgesia. Those are the ones that are the pain patches. Be very careful though when you're working with transdermal analgesia that you make sure you take off the patch before you put a new one on. Also, these patches are not MRI compatible, so we need to make sure that we take them off when they're going to MRI, because it can burn the patient and cause issues if they need to go for a procedure or a treatment. So monitoring side effects, very important. If we are giving them narcotics, opioids for pain medication, we need to understand that narcotics and opioids tend to have a respiratory depression effect with them. Hypotensive, will lower their heart rates. So make sure that we are monitoring their side effects frequently to make sure that we're not putting them in a state where it's dangerous, it's too much. Opioid misuse risk. So there's always that worry, especially by the parents, that if we're giving narcotics, that the patient's going to become addicted to these narcotics. And this is a way we can help the parents, educate the parents, and saying that if they are truly in pain and they really need the medication, then they will not become addicted to this medication, and that we will monitor it very closely, and that we make sure that we don't give them enough, that we use, and this is a way we can use, if we use the narcotics, opioids appropriately, then there's a low risk of opioid misuse risk. And if we do give them opioids on long term, then we can medically manage them and help them if they do become physically dependent on those medications. It can happen, especially patients that are in the ICU or receiving pain medication for painful procedures. Often we can manage that risk, but we need to make sure that when we are assessing the pain, that we are giving the appropriate pain medication for that pain that they're having. So that's why the assessment's very important. That's why it's very important to give the appropriate medication for the appropriate pain scale that they're giving you. So we also need to, again, evaluate how effective our pain regimen is. Is it working? Are they reporting a relief in pain? After you give them a pain medication, we go back in there and reassess them. Has their pain gone down? That's what we're looking for. Or is their pain the same? Do we need to try something different, different medication, a different regimen? So this is something that we can work with the providers to determine the best regimen for that patient based on the pain that they're experiencing. So physiological consequences, if we do not treat pain, like for a long time, people didn't think that infants felt any pain, that they didn't experience pain the same way that adults did, but that's not true. We know that infants do experience pain, and that if we don't treat their pain, there are different consequences to that pain. Basically, the infant can become stressed and anxious. They can be very difficult to console. They're not going to eat very well. We may, if it's a long term, their development can be delayed because of these pain. And also the behavioral indicators. So a lot of times infants will withdraw. We think they're out of pain, but all they're doing is they're shutting down. They use their coping mechanisms, the only ones that they know how to do, and they shut down and they will sometimes just go to sleep, and they sleep for long periods of time. So we need to understand that infants do have pain and assess their pain and give them the appropriate pain medication as well. So different pains that we talk about, painful procedural sedation and analgesia. So we usually give medications if you're putting a chest tube in, that is a painful procedure. So we're going to make sure that they have sedation for that procedure. A burn dressing change is very painful, so we make sure that they have the appropriate pain, sedation, and pain control for those procedures. Perioperative pain or postoperative pain. It could be perioperative pain because if you have a patient that is waiting for surgery, they need to have pain control before they go to surgery, and then when they come back from surgery, we need to make sure that we continue to manage their pain, because surgical procedure, they have a surgical incision, that can be very painful as well. And we can manage those with a combination of medications, like I said, included the non-opioid, which is your Tylenol and ibuprofen, and maybe some Toradol or Ketorolac, and then also your narcotics as needed. So burn pain is very, very painful for these patients. We do see burn patients at Valley Medical, and they do have a pain center, and they have a very good pain team there, but sometimes it is challenging because of the pain that they're having. So sometimes we might use a couple different, maybe some pain medication, as well as some benzodiazepines, like a Versed, something that will help them with that pain and able to tolerate that procedure. Other things that we have to take into account are pain states that children have, like headaches, if they have tension, dental braces, weakness of eye muscles, sinusitis, epilepsy, sleep apnea, or injury, they could have recurrent headaches. So make sure that we do our assessments and understanding what they're having their pain for. Abdominal pain is a current common complaint in pediatrics, complaining of their tummy hurting or just being very upset. We have to also assess what may be causing that pain and treating it appropriately. Is it a pain because of surgical incision? Is it pain because maybe they're very constipated? So understanding what that pain is related to is important to being able to treat that pain. And then pain associated with sickle cell disease, and we're going to actually talk about sickle cell disease in more depth later on in this course, but pain for sickle cell is very painful for them when they come in a sickle cell crisis. They are experiencing a lot of pain, and understanding what that pain is being caused by will help us treat that pain. Cancer pain in children. So a lot of children with cancer will be in chronic pain, and we have to treat that pain appropriately. We definitely use different modalities for that pain, narcotics, maybe some benzos, distraction, other techniques, the non-narcotic or non-medication techniques as well. And then we'll talk about end-of-life care and some pain and sedation for that. Basically, we keep them comfortable in an end-of-life situation. We keep them very comfortable. Sometimes we're a little bit more aggressive with their pain control, a little bit more, we have a little bit less, we will treat that pain so as they are end of life that they are not in any pain. The goal here is for them not to be in any pain, and so we are a little bit more liberal with our pain medications at end of life. Here's a question for you guys to consider. Which of the following is an important factor for consideration in understanding the pain experience in children? So children cannot tell when they're hurt. Children may not admit they're having pain. Narcotics are dangerous drugs for children, or children's sensitivity to pain is less than that of adults. So consider these answers and let me know what your thoughts are. Thank you.